There's been a lot of buzz about GLP-1 medications like Ozempic, Wegovy, and tirzepatide, especially now. Big names like Serena Williams, Oprah, and Charles Barkley are talking about healthy weight loss effects and longevity benefits. We want to take that apart today, discuss what's real, what's hype, and how we're going to be able to leverage these powerful pharmaceutical tools in a comprehensive approach to long-term success and longevity benefits. You're listening to the Beyond Healthspan podcast, a podcast that strives to decode longevity research to help you live better, longer, without the guesswork. I'm your co-host, Rich. I am a senior scientist and a health coach on the clinical team at Healthspan. I'm joined by Jim, is our Chief Health Innovation Officer, and also a health coach. Today, we're joined by a new guest, Brian Mack, nurse practitioner, Director of Clinical Operations. Is that correct?
Yes, that is correct. Happy to be here. Thanks for having me, Rich, and glad to be hanging out with you and Jim today. Talk about some GLP-1s. I'm new to the team, but have been working in the telehealth and metabolic health space for about 4.5 to 5 years now. So excited to be here.
We're excited to have you. It's an absolute pleasure to get to chat with you in more detail than just messaging back and forth over the previous collegial ventures that we've shared, Brian. And I know you and Jim are good buddies. There obviously couldn't be a better time to dive into this topic. Our discussion for this week around GLP-1s for weight loss and longevity benefits. We're going to have a slight shift in the format in terms of our agenda for today's discussion. We're going to start with the clinical, the actionable insights, the what, the how, and the how much. And then we're going to move to the science, the research, the why, the what evidence portion of our conversation in the latter half. A lot of great stuff to chat about, so let's dive in. Jim, kick you off here with a nice question to get you started. I'd love to have you, if you don't mind, do a quick or a rapid review, if you will. GLP-1s, this class of medication. Can you tell us a little bit about the dual agonists, how they piece together? I know there's some common brand names tossed around. Just give us a little bit of the lay of the land before we dive in.
Yep. Rich, I think we're kind of at that stage where we're third generation. We had things like liraglutide, that first generation, pretty good weight loss. Then we had the Ozempic craze, everybody talking about Ozempic. I kind of call that second generation. And now I think we're at that third generation. Don't get me wrong, the second generation is still a fantastic medication. We even see people still getting benefit from that first generation. But now you have the tirzepatides, the Mounjaros, the Zepbounds that are really giving us that exciting 20% weight loss when coupled with something we're going to talk quite a bit about is the proper nutrition, the resistance training, and the medication. If you are just going to take the medication, the expectations are going to be that the weight loss will not be as meaningful. That 20% that we see with LaFountain is when you do all three of those things. This is not a passive treatment or a passive medication. You need to do your resistance training. You need to prioritize protein. You need to eat nutrient-dense vegetables. So at the end of the day, we want people to go on this journey and this medication when appropriate. It's not for everybody. Some people are going to do great. When you look at Oprah and her wealth and the effort in the decades of not being able to succeed, and then she was able to succeed. You have world-class, athletes like Charles Barkley and Serena Williams that have wealth was never in the way. Having to feed their family and carpool were never in the way for them the way it is for us as normal mortals. They still struggled. Serena, exercising 4-5 hours a day. Oprah, countless opportunities, professional chefs, best registered dietitians, doctors struggled. Charles Barkley, yo-yoing and having success on the medication, going off of it, realizing you need to go back on. I think at the end of the day, it's hard to argue that this is not a special class of medication. I'll even make one other point. I don't believe that the overeating causes the obesity. I think the obesity causes the overeating. We can dive into that with Brian and Rich. I know you like to dig into pathophysiology, but that's kind of my introduction.
I appreciate that very much. Definitely the generational thing has helped me keep track of these medications as I've also been learning, diving into the research more and more. We're going to get into talking more about what and how along the way with these medications, with these GLP-1s in this class. We're going to use the shorthand GLP-1s, although this will include what Why are we talking about GLP-1s this week? It's not just because of Serena, obviously. There's strong data, evidence that seems to be continuously growing. Have we reached a critical mass? To toss it to you, Brian, if you don't mind. What puts GLP-1s beyond Healthspan? Why is it a longevity molecule that we're actually going to help facilitate people having access to when it fits and when it is going to meet the needs associated with their Healthspan enhancement opportunities and goals?
Yeah, it's a great question. I think GLP-1s and these medications, as well as the dual agonists, certainly are very dynamic. They offer strong clinical benefits for major comorbidities, whether that's obstructive sleep apnea, chronic kidney disease, cardiovascular disease, which is on the forefront of many Americans' minds, very potent at weight loss. Both of these topics are so present for an aging population as well as a population where we are more burdened by chronic disease. And so working to address an obesity epidemic, as well as also working to reduce our overall comorbidity burdens is a win-win. And that's certainly what these medications can do. On top of that, they're fairly well tolerated if utilized appropriately with the correct nutrition, coaching, having the right lifestyle choices there, as well as also making sure we're taking a stepwise approach with the dosing, then typically really well tolerated. So you're not having the risk factors of significant blood sugar level drops or these other concerns that you would see with some other medication options.
Wonderful. Love that you led with the comorbidities. I think that fits well with some of our focus here at Healthspan, the labs and the longevity benefits. You also mentioned weight loss. I do want to make sure we get into the weight loss, and I guess I'm going to toss that to you, Jim. I know I've learned from you and looked at some of the research that you've shared. You've shared extensive research with me in terms of hundreds of pages of hard work that you've done over the years. One visual sticks out to me that I'll put up on the screen here, but I'd love to hear from your perspective, Jim, with these GLP-1s, why they're so powerful, and especially with the weight loss context as well.
Absolutely. This is a great depiction of a very dynamic, parabolic move as we get into these higher BMIs. And listen, we all know there's some shortcomings of BMIs, but at a population level, it's actually quite good. But just looking at this and letting the viewers have a chance to digest it, as the BMI goes up, the risk associated with type 2 diabetes peaks at about 88%. So at BMIs, even above, what we depicted here as 35, you get into the 40, 50, 60 BMIs, you are 88-ish% likely to have type 2 diabetes. And then there's another connection to it. If you look at the research from Roy Taylor, and we'll dig into it a little bit later, but if you lose different amounts of weight, 5% is meaningful, 10% is even more meaningful. But at 15%, if you lose 15% of your body weight at an elevated level, you are metabolically not the same person. All of these markers, whether it's diabetes, heart disease, liver, kidney, dementia, Parkinson's, you name it, you're metabolically a different person. And the chance of getting those diseases goes down exponentially. And from a longevity, health span, if you lose about 50% of body weight, this is again, Roy Taylor's research, you are going to live 10 to 15 years longer than your higher weight self. And I'm going to cue it over to Brian because he's fantastic on this, but it's not only the weight loss. The weight loss is a big portion of it, but we are seeing benefits around heart disease before the weight loss. We are seeing indications around dementia and Parkinson's before the weight loss. So the weight loss is incredibly important, but there are other things going on with the GLP and the GIP, the second incretin, and then hopefully third and fourth and fifth incretins that we're going to be incorporating in the coming years with other medications. You're seeing benefits across the board. So the weight loss is huge. It's probably the lion's share of the reason, but there are other things going on that we're still learning about that's incredibly exciting for longevity and health span.
I love that. Definitely love the mechanism stuff. We're going to set some time aside to dive into the mechanism. Brian, any additional notes you want to toss in on this particular topic?
Yeah, I think I totally agree with Jim. Weight loss is certainly impactful, but what really excites me as a provider is certainly these other downstream benefits where not only we're improving someone's health, but we're also improving their overall quality of life and health span, right? Not just simply the lifespan of they're living from this age to this age, but also that the quality of life and what they're able to enjoy and continue to do is also extended. And as you see in the chart you showed, maybe somebody who has, which I agree, the BMI is not a perfect tool or perfect data point, but it is a data point, where you see somebody who may consider themselves overall fairly healthy, BMI maybe 29, 30, 31, 32, and they may be healthy, when in reality, they're almost smoldering with metabolic disease and concerns down the road. If we can work to address those and prevent those from occurring before a diagnostic lab test, that's paramount. And that's what these medications, as well as the coaching, lifestyle choices, and the dietary choices, we can really leverage to improve that on a broader scale to the entire patient population, which is super exciting.
Okay. Couldn't agree more. I think that prevention element and some of the diagnostic criteria altogether, using these maybe more prophylactically or just to control weight loss, we're going to get into that, where they have this gateway potential. That being said, I wanted to get into a couple quotes that summarize this segment around why are we chatting? Why do these GLP-1s matter so much? Why have they made their way into our topic list and our discussions with Beyond Healthspan podcast? There's a couple quotes that I think are super useful, so I'll put those up on the screen as well. Eric Topol, founder of New Medical School, Cleveland Clinic, classifies GLP-1s as the most important drug class breakthrough in medical history. Medical history stretches at least back to in the early 1700s or beyond. If you want to go back to ancient Greece, that could be considered medical history as well. Nonetheless, all of medical history, these are the most important breakthrough drug class. That's astounding, a powerful quote. Similarly, Stuart Phillips, a renowned researcher, academic that myself, I know Jim, and others within Healthspan and some of my other colleagues and friends look up to quite a bit, associated with exercise science, protein research. He classifies this or suggested that there's no doubt that this newly recognized class of weight loss drugs, the watershed discovery, could improve lives for generations to come. They are making these strong statements, and this is just one of, these are a couple examples here. So definitely the right time to focus on it. The marketing campaign with Serena Williams and multi-year data that's coming out seems like we're reaching this critical mass. I wanted to transition, if you guys are okay with that, maybe talk a little bit more about, and I think Brian touched on it pretty well, the sustainable solutions associated with health and longevity, including GLP-1s. I know, Jim, maybe you can talk a little bit about the developments that are upcoming there, but also the personalized coaching, the community, the relationship building. Why is that important? And why is that where Healthspan has invested significant resources to make sure we get really great people like Brian and Jim to join the team so that we can coach and accompany these amazingly powerful medications with the right lifestyle?
Yeah, so I'll start because I always like Brian finishing up. Right now, it's primarily a shot, your Ozempics, your Mounjaro, your Wegovys, Zepbounds. There is an oral, Rybelsus. I would say mixed success from my experience, and I'm sure Brian can comment on that as well. I think it's important that everyone understands this is a multimodal approach. You're going to take your shot in most cases once a week. The period after that, up to 24 hours, you're going to feel different. You need a coach to help if you're having side effects. The people I've worked with directly and indirectly around this medication class, they're not seeing discontinuations because of side effects. They're very manageable if you have coaching, somebody to work you through the nutrition, constipation, mild nausea, all the different things that come up, and we hear all these horror stories on the news and in Reddit and all these different channels. Those are vocal minorities from my experience. If you focus on nutrition, do your resistance training, will help with the Ozempic base and losing our butts. All those are things are manageable. And I think we're going to talk about Grant Tinsley's research at some point. You can preserve muscle. You can lose predominantly fat. You're going to lose some amount of muscle, but you got to prioritize your resistance training. You need to have a program around that, be thoughtful around that. Different exercise programs are good for cardio, but they're not necessarily going to help for muscle preservation. We want to have a very well-defined protein target. We have a proprietary model that we use to make sure you're dialing in your protein, eating the right kind of fats, eating carbs. Again, one of the things I always joke about, Doritos are not broccoli. You can demonize carbs if you're talking about ultra-processed foods and chips and stuff, but I have a hard time seeing anyone in all the experience I have and all the research that somebody overate broccoli and they didn't succeed around their goals. So that's kind of my overlay real quick, but I'd love to hand it over to Brian.
I totally agree. I think the reality is that these medications are exceptionally strong and potent and awesome tools. But in order to really optimize as well as find the most sustainable options with also, in my opinion, the best success, it's going to be to partner with a coach and making sure we are taking care of the whole patient holistically. And I think by doing that, you're realizing it is a journey, not a sprint. It's not taking these medications for 6 months to hit a particular weight goal and then coming off of them cold turkey. You're really looking to utilize these medications to help hit goals, your healthcare goals, work with a coach on that. That may be weight related. It can also be related to a plethora of other healthcare goals down the line, whether that's liver health or improving other facets of your life. But we need to make sure we're fueling the body appropriately. So prioritizing protein, whole foods, reducing processed foods, because like Jim said, and I totally agree, from working with patients, the patients who I've had who have really struggled from a nausea standpoint or some of these symptoms, it's because they haven't made those other lifestyle choices and changes that we need to have. Still having processed food, still having fast food. Those are things where you can have an uptick and an increase in nausea and not feel well, which we certainly don't want to have. And that's one of those things that you can learn on your own, but it's really best to be working with a coach who's experienced in that field, who can help guide, give suggestions. Hey, how do you start to increase your exercise if you haven't exercised in the last decade? How do we get you there? And that's what our team here can really help with. That's what I'm so excited about, because when people really leverage all of those things together, it's like they unlock a completely different individual inside themselves, which is super awesome to see as a provider.
Hey, Rich, with our population, if you want to go on this medication through Healthspan, you have a coach. Everyone with us has a coach. You're going to have a strength and conditioning program. You're going to have a nutrition plan. You are going to have labs. We pay for the labs. So it's included in the price. We think labs are incredibly important at baseline. And periodically, most times when we run those second set of labs, it's not because we're worried, we're celebrating. Wow, your triglycerides are better, your HDL's up, your LDL's down. Not only are you seeing the scale, your waist circumference, we have people using bioimpedance or smart scales and they're seeing their body fats going down. So we want to run labs on that one off that maybe there's some contraindication, but at the end of the day, we're going to have you do this right. We're not just going to say, here's the medication. We want to make sure you succeed. We have Brian and the team around to make sure that if you have to deal with some constipation, nausea, you have a coach, you have a provider assigned to you. And at the end of the day, you're going to get answers from us and we're going to help you navigate this.
Yeah. Be cautious out there. There's a lot of places where you can sometimes get these medications. I would be really cautious if there's not an oversight or a program that's tied to it. That's something that is super important to your success as well as patient safety in general. So making sure that there's an oversight and clinical support is paramount.
All right. I wholeheartedly agree. I appreciate both you guys chiming back and forth. That dynamic was awesome. I continue to learn from you guys, especially on this topic. I'm not quite caught up to where you guys are, but I'm excited and learning more every day. Jim teaches you whether you want him to teach you or not. I love that. I have this proverbial minivan in my head. You're the patient. You get in your minivan. Jim hops in, Brian hops in, and you're on your way on your longevity journey. And I think that's crucial. You're not just riding your Vespa around by yourself, unprotected, without all the safety equipment that a minivan provides and friends to help you get where you want to go. I do want to touch on the dosing. This is, you can memorize the doses, 0.25 or 2.5 and how they increase. I hear things about microdosing all the time. I'm starting to see some research data around microdosing here and there. What is microdosing? Is it a real thing? Can you help define it for me? Jim, I've heard you talk a little bit and educate me about what microdosing is because it comes up all the time. How does that play a role with Healthspan's approach to GLP-1s?
Yeah, we have a simple philosophy, minimum effective dose. We also think about slow and low. What do I mean by minimum effective dose? Most programs move you up month by month, regardless of how you feel, regardless of how much weight you're losing, regardless of just your energy levels. We're not going to do that. We're going to have a conversation with you every month before your next titration and make an informed decision on the right dose. Taking Zepbound as an example, it goes from 2.5 to 5, 7.5, 10, 12.5, 15. A lot of programs, after the first month, you're going to 5. Then they're not going to ask you, hey, how do you feel? What's your weight loss? Are you losing too much weight? There is a situation where you lose too much weight and you're losing muscle. Every month, we're going to help you titrate. And more times than not, we're going to stay at the lower dose. And to answer that other part of your question, the microdosing, there's no definition. Some will think microdosing staying at the 2.5. Some people are cutting that minimum dose in half and saying that's a microdose. We don't have really good research on doses lower than what was tested. Spent hundreds of millions of dollars testing on thousands, tens of thousands of individuals. We want to keep you at the lowest dose, but we don't believe in cutting that 2.5 to half because we don't have great research. We have good research on the 2.5. So we would love to keep you at 2.5. Maybe you go up to 5. The lion's share of our patients will be on a very low dose, which is twofold. One, you're having a lower dose. But two, if you want to get off at some point, instead of coming down from 2.5 all the way up to 15 and coming all the way back down, that's a lot of change in the body. But if you're staying at that 2.5, 5, and you decide that you want to get off of it, it's a few steps down. And also your body is not adjusted as much. So we don't want to become over dependent on the medications. The biggest problem with these, again, I'm not going to be critical of others, but if you accelerate the dose too fast, you are going to lose more muscle than you should have. Muscle is longevity. Muscle is health span. And we want to make sure that you're not in a situation where the scale's moving, you get to that goal ideal weight and you don't like the way you look. The people that I work with, when they get there, they're happy to be there. Sometimes it's kind of exciting because their goal weight may be 180, and at 190, they look amazing. They feel amazing. So because they lost fat, they didn't lose muscle. I've seen a situation where people went past their goal weight and didn't like the way they looked.
Yeah, I totally agree with you, Jim. I've had similar experiences where patients just kind of throw a dart against the board and they say, well, this is the number that I think I would be good at. And they may be 15 pounds away from that number. And they're like, I had no idea I could even get here, but with the strength training and the dietary choices they're making, they're like, I don't want to lose any more weight. And I think that's a really awesome experience when that happens. Also, why it's so important to have that coaching and the collaboration and monthly check-ins to have the patient centered in those discussions. I think the other topic that kind of comes up sometimes, that not necessarily microdosing, but also where patients will want to space out their dosing, or they will say, I'm going to take it every 10 days, or my local care provider said I'm going to take it every 14 days. Very similar to what Jim said. We don't have great research on that. So when we're having our discussions of our dosing, it still will be the weekly dosing, but low and slow administration for the drug to help and support the patient. I don't think we need to rush up on a dosing amount. I don't think that necessarily just is a derivative of automatically good patient outcomes. I think sometimes that's a discussion that you have to have with the patient to help them understand, because Reddit or a commercial may give them the opinion that they have to get to the 15 milligram dose of Zepbound in order to see success. And that certainly isn't the case. That's where those biomarkers, those labs, as well as trending that data and having the coaching discussions is so critical. I love to even just see just the non-scale victories, right? What are the things where your clothes are fitting better? Now you're walking outside and you're doing things that you never were doing because you didn't have the energy, and now it's just a part of your day-to-day life. Those are just as awesome for me as a provider to hear from patients.
Okay. So just to summarize, GLP-1s are a gateway drug to better longevity. They will unlock a new you that has greater capacity and greater metabolic health, where I think we've talked about this in previous episodes, where if your mitochondrial health is kind of not in a spot where it needs to be, you can invest in the lifestyle habits, but sometimes you're spinning your wheels, not having the traction that you need. And I think GLP-1 sometimes just bring down some of the barrier to entry to seeing some of those benefits, reducing food noise, all that stuff. So wonderful. I want to transition again, if it's all right with you fellas. How do we assess success using GLP-1s? Is it weight loss defined based on a percent reduction from a baseline body weight? Is it some kind of bio-age, score? Is it labs? Again, non-scale victories, like you mentioned, Brian. I'll probably kick it to Jim to start. I think you had brought up Roy Taylor's research, and I wanted to make sure that if you'd like to touch on that again with a little bit more detail, I can try to make sure I get that figure up for folks to see if they'd like to follow along.
So I actually think the win is determined by the patient or the member that we work with. People have this weight, whether it's their college weight or their high school weight or something like that. And I've seen on other programs, people doing crazy calorie restriction or diets that are not sustainable for more than a short period of time. I've seen like water fasts and stuff. You're going to lose some weight, but a lot of it's going to be water. And if you lose too quickly, a lot of it's going to be muscle. And I think the number on the scale becomes less relevant. It's clothes size. I think Rich mentioned it. The scale didn't move this week, but I'm in a belt notch or that pair of jeans I loved wearing again. Like those are really cool non-scale victories. We encourage everybody to use a bioimpedance scale, those smart scales. They're now like $50 and the accuracy has gone up. The American Association of Endocrinologists are now endorsing them. People are using them for studies. These things used to be pretty gimmicky. Now they're actually getting pretty reliable in terms of giving us other markers. Using that, Rich mentioned BioAge. We run labs and we have your BioAge, your systems age. We look for all those other wins. And I think those are really important. But it comes down to the why of the individual. One of the best stories ever here is I can now get off the floor after playing with my grandkids. Like that's like the big, huge wins. Like Brian said, I've had literally people that couldn't make it to the mailbox that are now walking half marathons. True story. Multiple people that couldn't literally move around their house on these medications and also doing it through nutrition and lifestyle alone. Those are just amazing things. Brian and I always joke too, is like, we have seen women get pregnant that have been struggling for years. And like when, our previous clinic, we had to release people when they got pregnant. And that was like the best day of my life. Like I hated when we lost patients, especially ones that you created bonds with, but there was nothing better than, hey, I'm leaving because I got pregnant after trying for years, decades. Anybody who's gone through that know how that can just, melt your heart.
I think when you look from a numbers perspective, anything above 5% of your body weight loss is certainly a success. Over 15%, like Jim called out at the beginning of this podcast, is massive metabolic improvement. Similar to Jim, I love looking at the numbers, but some of the non-scale victories are life-changing. I've had patients, just recently this year where they said, hey, I went to my daughter's college graduation. It was the first time I took pictures with the family for a decade. But because that patient had the confidence to do that, liked how they looked, felt comfortable in their skin and to do that. So to see those kind of changes, in addition to these wonderful ones on the slide that you're sharing, which are also awesome, those are the things that get me so excited. But that's where it is so critical to make sure you're partnering with a team on that journey to really help support you, to make sure that you feel equipped to tackle everything that life may throw at you, to make sure we're not getting derailed and that you have the adequate support while you're on this journey.
All right. Appreciate it. I think that some of the things you guys had brought up, like the quality of life, the infertility and or gaining more fertility, are included within this figure. You probably don't have to lose at least 5% to improve your quality of life in terms of body weight. It's going to be individual, like you guys mentioned. But I did want to just put this up there just because it just shows the potency of these medications in that you can achieve real weight loss that actually has, I guess if you want to call them like these, these other areas, these other benefits or these downstream effects that are not just the numbers on the scale like you guys had really focused on in your reply there. Yeah. So appreciate that a ton. I know we talked a little bit and Jim mentioned measuring success, the data we track, the cadence of our labs. All of that's going to be important. I did want to maybe just get into a little bit about like, who's this for? We've talked about these benefits, weight loss, the individual outcomes that are sometimes very personal associated with fertility and that type of thing. Who fits for GLP-1s within this Healthspan model? Who should consider? Maybe who should avoid? I know, Jim, early on, if you think back to some of the first words you said in our podcast today, you mentioned these are not for everybody, and that certainly is true. I just want to give folks listening, who's a good candidate for these? When should you consider these? And when should you set up a call with Jim to learn a bit more?
Sometimes we get put in these buckets based off of insurance coverage or what an employer health plan may cover. That certainly is one category based on what those companies or PBMs may decide. From my perspective as a provider, I don't think it's as simple as just looking at a BMI. You need to look at the entire patient context. BMI isn't a perfect description and it doesn't fit everything. You could have somebody who has a BMI of 24, but they have significant family history of cardiovascular risk, or their GFR is trending down to where we're considering this to help provide those kidney benefits. With anyone who has interest, certainly reach out. You could discuss with us, see if this is a good option or candidate. I personally, as a provider, don't believe that you need to only have a BMI over 27 or have a BMI over 30 for this to be a potential option. There's just more nuance to patient care and practicing medicine than that.
Brian, I love that too. I had a number of patient calls today, and it's probably 50-50 of me talking people out of trying the medication. We still really believe in nutrition. I have a PhD in nutrition science. I have a master's in nutrition science. I really want nutrition to be the answer. And it is the answer for a lot of people. And sometimes it's part of the answer for a lot of people. But, if you want to come and work with us and you say, I don't want to do the medication or I don't want to do it now, we love the idea of working on nutrition, sleep, stress, and resistance training. So we're happy to do that. And at the end of the day, we just want to see you succeed and have all the tools available to help you succeed. That's what really matters. We want nutrition to be part of the solution, regardless of whether you go with or without medication. I've had people lose well over 100 pounds without the medications. Is the success rate of people losing that kind of weight or losing 10 or 15 or 20% of their body weight with the med? Yes, there's no doubt about it. I'm seeing a much higher success rate for people that need to lose, that extra 50, 100 on the meds. But, your journey is your journey. We want you to own it, and we're not going to force you in one direction or the other.
I think the thing I would add to that is that's where it's so important to have the low and slow approach to the dosing. Somebody could start from a dietary standpoint and they may knock it out of the park from a dietary and lifestyle standpoint and not need any, this medication at all, which is great. Then we're still hitting our healthcare our goals. We're still supporting patients. That's a win-win for me. If we get these goals and we're at tirzepatide of 5 milligrams a week, then we can work, if the patient wants to come off that medication, we can work to stepwise that back down and make sure we're transitioning them while trending those biomarkers and making sure this is a sustainable solution to allow them to hit those healthcare goals. I think either approach is fine. The big take home is humans just aren't as simple as to say you belong in the BMI over 30 box or the 27 box, and that's the only way that you can get it. At least that's not our perspective here at Healthspan.
I appreciate both of your insights. Let's take a look at, from a longevity standpoint, why these are so powerful beyond the weight loss. We've touched on so many of these comorbidities, infertility. We made mention of some of these things. Obviously, the amount of research invested in GLP-1s, the dual agonists, and maybe even some other next generation type stuff, which I'm sure we'll get into. What are some other on-label uses? I know they're approved for more than just weight loss. So I'd like to just broaden out a little bit with the longevity angle, just as you guys are kind of mentioning the low and slow approach. You don't always look to a GLP-1 only to achieve weight loss. Sometimes you're looking at it as a longevity enhancing tool, a geroprotective molecule based on some of the evidence, maybe a little bit similar to rapamycin. Both of these might have longevity enhancement potential, so maybe start with Jim. I think we started with Brian last time.
I love you. I'm glad you mentioned rapamycin, because if you want to think about the two medications that hit all the 12 hallmarks of aging, myosin and it's the GLP-GIP combination, I think you are able to hit a lot of longevity markers at the same time with these medications. Because, if you look at like fasting or time restricted eating or different nutritional approach, if you're not hitting all 12 of the hallmarks and you are with this medication, I think it was the CEO of Eli Lilly. And I know, again, people are like, ooh, boo, big pharma, but big pharma to bring these medications, they're spending hundreds of millions of dollars. I think they have 104 trials going on right now. These trials are $20 million. These are huge, expensive trials, even more in many cases. I think we're going to see regularly, like right now we have indications. Brian, if I missed something, correct me, but we obviously have diabetes. We now have indications for liver and kidney and heart. Obviously, we're well aware of the weight loss potential and benefits, but we're seeing a lot of downstream benefits that are not necessarily associated just from the weight loss, maybe 80% weight loss, but there's other things going on. There are GIP and GLP receptors on almost every one of our cells. I think the exciting stuff that's coming is around potentially dementia, Alzheimer's, Parkinson's, where we're going to see not necessarily that they will completely prevent, but I think they're going to delay. And, having a father that went through that, if that was delayed a year, 2 years, 5 years, those are really precious times. So I don't think they're going to cure it, but I think we're going to see delay onset. I think we'll see people going into nursing homes later in life, hopefully having more health span versus lifespan. The way I kind of define that is lifespan is how long you live, of course, but the health span is the non-nursing home years. I think
Yeah.
anybody who's dealt with that realize that that's a quality of life that a lot of us don't look forward to. So at the end of the day, I think we're going to see more and more indications for these medications in addition to what we're already seeing.
I totally agree. I think what I'm excited for is how this is going to really help shape addiction and those aspects of society and how we can better manage that chronically for patients, because that all streams into that health span. How can we get the most out of life, our quality life, and enjoy life as well? Another example of kind of those downstream benefits is the simplicity of if we can reduce obstructive sleep apnea in a patient population, which then has the downstream benefits of cardiac and reducing the risk of AFib and these other things that really start to complicate patients' care and also have a higher cost of care. And so, if we can work to do these things proactively versus having this tertiary or reactive approach, that would be ideal.
All right. We've made our way through the why and the how, also through some of the longevity, the broad indications and the comorbidities that these medications are able to address. Love to just touch on one other thing. I know we're going to get to some of the actionable takeaways, but I wanted to pause real quick on some of the newer stuff that's coming out. Some of the, we talked about GLP-1 receptor agonists and the dual receptor agonists. Is there such thing as a triple? Will they always be injectables and only injectables? I'm looking mostly at you, Jim. I know we've chatted about this, and to me, that's an exciting idea. I've not done the volume of coaching with folks on GLP-1s that you have or Brian has, but when I have worked with folks, sometimes the injectable is innocuous. It's not a big deal, pretty painless. That does put some people off. They're a little bit concerned about that, or it's just not part of what they want in their weekly routine. What's down the road? What kind of exciting things are coming up in the GLP-1 space?
So the oral should be out first quarter of next year. Instead of being a once a week shot, it will be a daily pill. Weight loss probably won't be as high as the shots. The success with people on Zepbound is between 15 and 20% average. I've literally got people that are 40% and feeling great about and looking great at that level of weight loss. The orals are coming. I would expect the orals to be more 10 to 15% weight loss. Still phenomenal, still getting you very close in many cases to that 15% level. We see all the benefits of the chart and depiction that Rich put up. The one that's kind of exciting is what they call the triple G, the two-tide. That one is 3. So it's the GLP and the GIP that you see in Zepbound, but then they add glucagon. What that literally does is it takes glucose. We store glucose in our liver and our muscles. Muscles are very stingy. Like the bicep doesn't share with the tricep, the quads don't share with the hamstrings, but the liver says, hey, I got some energy here. I'm going to give it to whoever needs it. And what this medication does is it takes glucose from the liver and sends it to the muscle where it's going to be burned for energy, ATP. What is great is now you have capacity for your next meal or circulating blood sugar to go into the liver. This is amazing. We are seeing numbers, and I know people in these trials. These are unbelievable numbers, like 25, 30%, 40% weight loss, and it's maintaining muscle. We have another generation coming. If you need to lose that 10 or 15%, you're going to be on a low dose. That's what's exciting to me when I look at some of these next generation. It's not that you need to lose 30, 40%. It's like you're going to be on a really small dose and get 5%. 10%. The trial that they have going on, 100% of the people lost at least 5%. Every single person lost at least 5% on low doses. Right. So that's what's exciting. Everybody's going to have at least 5% success with this med. The numbers, as Rich and I were joking about earlier, is actually even better on women. The higher the BMI in women, the more weight they lost. That's exciting, especially when we have a population, post-menopause that's dealing with these things. So it's stronger in women, people losing more weight, the higher their BMI, the more weight they needed to lose, they lost a larger percentage. And I think what's great is we're going to be able to have really low doses. And then I think you're going to see not only a weekly shot, they're working on a monthly shot. There's research, I think, out of Stanford University working on a quarterly. I think at some point we'll get to the point where you may take the shot once a year and get the benefits, all that heart protection, liver, kidney, neuroprotective. I've heard some incredible speakers say that if you're a baseball person, you're in the first inning, second inning of what we're going to see on these medications. If you're a football person, this is early in the first quarter. We're going to see more and more a lot of off-ramp medications too. There'll be medications that when you decide you want to get off of the shot, there may be a nice oral pill that helps you transition, and you have different stages of your journey. So we're just going to see more and more. There's some amazing companies, tremendous amount of money being invested right now. In terms of longevity health span, I think our health span that, we have the gap growing, especially in women, we're going to start seeing that gap close. That's what's exciting about these medications as well.
Super exciting. I agree. Put my hand up for the football fan, so I appreciate the reference there. Cool. I would like to transition to some actionable takeaways, and we'll probably kick it to Brian first. If you're curious about GLP-1s, what should you do next? What lifestyle habits, and I know we talked about these, but just kind of to sum things up, kind of put a nice package around everything.
I think the thing is, with everything, it's always good to do some research and have a conversation. My preference would be that you're having that conversation with a medical provider or somebody experienced in the management of GLP-1s, especially, and asking your provider those kind of questions like, hey, if you were to prescribe this, how are we going to monitor it? What would this look like? What's my follow-up look like? That's important to make sure you have that support. If it's not a medical provider, but a coach, you can certainly have a lot of great coaches. I think working with a team and somebody who's familiar with it is really critical, especially to understand the nuance of dosing and the symptom and side effect management. Starting to work on even just small aspects of mobility while you're thinking about it is great. So trying to carve out some time walking, breaking that out to 5-10 minute walks, a total of 30 minutes a day, doing 10 minutes of walking after a meal, these smaller interventions to start really priming your body to get ready for these changes would be ideal. And then you start carving out those habits, which would be ideal, focusing on nutrition, working with a coach there, prioritizing protein, lifting weights, strength training. Those things are critical. You don't have to do that every single day, but doing it a couple of times a week is certainly very helpful. And then prioritizing sleep. I'm not the best at this, but this is super important. So making sure that you are carving out that time to allow your body to rest, to recover, to get quality sleep. Those are all great next steps.
Great. And I don't want this to sound like a promotion for Healthspan, but we're doing things a certain way. And this is why we're doing the podcast. We want people to hear how we're doing it. Our coaches have at least a master's in the field. We have 2 PhDs. We have coaches that are certified trainers or have backgrounds in exercise. We have special training and experience in sleep. And my personal belief is if you're not sleeping well, everything else becomes incredibly hard. We work on sleep, but stress, obviously nutrition, the strength and conditioning component, how to do the right kind of cardio. So you're going to get that. You're going to get labs because we want to make sure everything's lining up and let you see those important markers. But we are doing things a little bit differently. We want to surround you with all the levels of success. You're going to have access to our provider team. We do monthly check-ins. You have a coach 7 days a week that you can message, hey, I'm having something going on. What do you think? Or my girlfriend's doing this. Should I do that? Or my husband's suggesting, my wife's suggesting. You have a coach that will be able to get through the noise. There are a lot of very good actors out there. But there's a lot of actors out there that are just trying to promote their supplement line or something that is not science-based. I can assure you, if you work with us, everything we're going to be able to provide you the science on, and we're going to make sure that we put your best interest before anything else.
100%.
All right. Thank you, gentlemen. I appreciate it. It was amazing to learn from you guys. Looking forward to working with more of the Healthspan community along the way. That's it for this episode of Beyond Healthspan. We hope you're walking away with some new insights, maybe a little inspiration for your own Healthspan journey. We hope that you will take this advice to live better longer without the guesswork. If this sparks something in you, please share it with a friend, drop us a comment, or let us know what you'd like us to explore next. We'd love that, and we would be glad and grateful to hear from you. We're building a community that's curious about living longer and better, and we're glad you're here. Thank you so much.